like a PhD project that has got impact in our department. And you can see the application of this project in the department is involved now in operations. Okay, Ashlesha, please start.
So, thank you. Good morning, everyone. So my project is on enhancing precision in CyberKnife and Linac-based lung SBRT. So lung cancer is the leading cause of cancer mortality. SBRT has shown to improve local control and overall survival for early stage lung cancer. And the Chisel trial showed that the outcomes are much better than conventional radiotherapy. And some trials, including the STARS trial, have even shown it to be comparable to surgery. So with SBRT, we can deliver high VED safely, and the 3 to 5 year local control rates exceed 90%. But to make the best use of SBRT, there are still some clinical challenges that need to be solved. And the main one of them is to manage respiratory-induced tumor motion, which presents a lot of uncertainties during treatment delivery. And then the treatment of central and ultracentral lung tumors, which are at a high risk of severe toxicity. And almost all lung cancer patients have lung or cardiovascular comorbidities, so that requires us to be more precise. And some centers lack access to advanced motion management and image guidance, which is very critical for SBRT. And there's limited technology-specific evidence for certain treatment platforms. For example, CyberKnife also has sparse literature. And so these are the different aims that I'm going to go through. So the first aim, this has been published. So it was a systematic review on the choice of photon energy and Linac flattened unflattened beam in early stage lung SBRT. So the aim was to evaluate out of these 4 energies, 6 triple F, 10 triple F, which one is ideal for a good therapeutic ratio, while also minimizing the treatment time for minimizing the interfraction motion. And this was done as per the PRISMA guidelines, and that was the search string. So 473 articles were searched, and then 20 out of them were eligible. And so these were all the 20 studies, and most of them recommended 6 triple F. And so, in summary, 6 triple F was advantageous in majority of cases, offering superior OAR sparing with comparable target coverage. Triple F beams reduce the treatment time by 30 to 50%, which is essential for managing interfraction motion. 10 triple F was recommended for very specific cases of single fraction and where skin dose is a concern, but this was from very few studies, so there's not very strong evidence on that. And for cases with a cardiac implantable electronic device, energies more than 6 MV should not be used. And also for patients with a higher age and comorbidities, for that conformality, we need to use 6 MV. There were also some studies which suggested that intermediate photon beam, so 3 MV, could be useful for very thin patients, but this was a Monte Carlo study, so this is not clinical. And on the dependence of tumor size on the beam selection, the evidence was inconclusive. And so my second aim is to improve commissioning with a customized respiratory phantom. This is published as well. So these are a summary of details of lung SBRT commissioning at Charlie's. And so tumor diameter within 5 centimeter, these were the 3 fractionation schemes. Planning was done on 40 CT with average of the 1040 CT phases or maximum intensity projection for specific tumors. The motion management was free breathing ITV based, and later we used DIVH and EVH as well. The margin was 5 millimeter. both 6FFF and 6MB were used during the commissioning. And yeah, so 2 hours, 200 degrees, and KV plus CVC read for imaging. So one of the key components of commissioning was the patient-specific QA. So 20 test plans were created from 20 patients used to create 20 SBRT VMAT plans with 6FFF and 6MB using robust optimization. And so a standardized patient-specific QA protocol was used for these, and then the dose constraints were checked against many different reference documents. And the phantom measurements, which were the research novelty of this aim. So one of the key issues during dose measurement in dynamic thorax phantoms is that as we are measuring the dose from the tumor, the film is moving as well. And so the dose we measure in the film seems to be blurred. And so there's a large discrepancy in the planned and delivered dose. So to account for that, we developed a film insert which allowed tumor to move but kept the film static between the two halves. And so in this insert, we used tissue equivalent wood PLA densities, 93% in pill per lung, 24% in pill per lung. Included 3 centimeter diameter spherical tumor, and there was a fixation device at the inferior edge. And it also included included 2 halves, which put the film and then fix it together. So in that design, it also avoided any sort of friction damage. So plans were created and delivered with this. And then we also developed an ion chamber insert. So currently the commercial phantoms have the inserts which are not specifically designed for certain ion chambers. So to minimize the air gaps, we customized this one to be the exact dimensions of the CCO4 ion chamber. And this also included tissue equivalent densities. So 28% marble PLA for lung and 24% wood PLA for the tumor. And this also included a 2 centimeter diameter tumor in this. And the 2 insert halves could be screwed together after fitting the ionization chamber. And so the SBRT plans were again created for the 2 energies delivered, and the point doses were compared to TPS. So the results from these are presented here. So for the patient-specific QA, the gamma pass rate was about 98.8% with 3% 1 millimeter, which is quite good given the strict criteria. And the results from the phantom studies were, so the gamma pass rate with the film was about 95% with 3% 1 millimeter, and the ion chamber measurements were within 1.9% of the planned dose, showing the efficacy of these 3D printed customizations. My third aim, this has been published as well. So this is on patient-specific factors associated with tumor motion in lung SBRT from real-time tumor tracking traces. So this is a very important topic in lung radiotherapy to assess how the patient factors may affect the tumor motion, and if we can select for a given patient how much motion they would have and what motion management to use. And most of the previous literature uses 4D CT scans, which only has a few breathing cycles, so doesn't account for the interfraction and interfraction motion variation. So in this study, we used data, prospective data from CyberKnife fiducial tracking, which gives motion at 25 hertz throughout the fraction. And so this motion trace on the right shows the motion from one of the fractions of one of the patient. And the red parts are the treatment delivery node where the radiation was actually delivered. So I extracted the data for 109 early stage lung cancer patients treated between 2014 to 2024. And we only used the treatment delivery nodes, like the red parts of those motion traces, to avoid the impact of interruptions. And then this basically just describes how I calculated the individual respiratory cycles and quantified the amplitude in three directions, so SI, LR, and AB. And so given that it was done from all of these nodes and all the other fractions as well, it gave a very robust measure of tumor motion for each patient. And then regarding the patient factors, so this was basically all the routinely recorded clinical factors recorded in Mosaic and also LCPSM. So this included demographics, tumor factors, lung volume, BMI, lung function tests, lung comorbidities like asthma, ILD, COPD, and all of the medical history like the performance status, previous surgery or radiotherapy, and smoking history. And then for the analysis, so I initially did some univariate non-parametric tests, but I haven't included them here because we figured that there was some moderate inter-axis correlations between the three axes. So the results were interdependent across the three axes. So we decided to use a joint axis multivariate framework. And the figure on the right basically just illustrates that. So in the univariate analysis, I found that tumor diameter and previous surgery impacted the motion in the LR direction. And so the figure on the right shows the, so the points at the center are the mean motion out of all the patients, and the ellipses are the residual covariance. So we can see that even though only the factors impacting the LR motion were changed, the tumor motion is changing a lot in the SI direction as well and the AB direction as well. So this justified using the multivariate framework. So these are the final results for this aim. So what this showed was that the lower lobes showed 8.2 millimeter more motion than upper lobes, and prior lung surgery or radiotherapy reduced LR motion by 0.5 millimeter, which may not be clinically significant. That's quite small. But for the lung function and BMI, the results could be quite significant. So each 10% decrease in FEV1 reduced the SI motion by 0.4 millimeter and the AP motion by 0.1 millimeter. And so considering like if a patient with severe COPD has 25% FEV1 and someone with normal lung function has 125, this could like go up to 4 millimeter there and could be significant in the SI direction. And similarly for BMI, depending on the difference, this could reach up to 4.5 millimeter. And with the tumor diameter, the LR motion increased by 0.02 millimeter per unit, which was relatively small as well. So, and all of these parameters are available even before treatment planning is done, so they can help stratify patients based on their motion risk. And although the data is from CyberKnife, but the results are valid for basically any treatment modality because they're showing how the intrinsic lung tumor motion varies with the patient factors. And so our fourth aim is on reduced PTV margins in central lung SBRT with CyberKnife fiducial tracking. So SBRT for central and ultracentral lung tumors remains limited due to the high toxicity risk. And with real-time tumor tracking, we can use smaller margins as we don't need an ITV. But currently, a 5 millimeter PTV margin in CyberKnife is used for all locations in the tumor, irrespective of whether they are central or peripheral. So in this study, I evaluated the possibility of using optimal location adapted PTV margins with CyberKnife fiducial tracking. So this included 122 retrospective lung cancer patients, 107 primary and 15 oligometastatic cases. And the tumors were stratified based on the distance from the proximal bronchial tree or esophagus. So within 1 centimeter was ultracentral, 1 to 2 centimeter was central, and more than 2 centimeter was peripheral. And I use the band hook margin formula. So for patient-specific margins, the systematic error would be the standard deviation of per fraction mean errors, and the random error would be the root mean square of per fraction error standard deviations. And the alpha, beta, and sigma p are constants, which are pretty standard. And so now I'm going to describe the different sources of uncertainties in CyberKnife fiducial tracking. So the main tracking errors are correlation error and prediction error. So in CyberKnife, it uses the correlation between the external marker signals and the internal fiducial position to create a correlation model. And so every new X-ray that is taken is used to update that model. And it's usually a linear model. So like you can see on the right figure, that's the 3 linear models for the 3 markers. And every new image that we take contributes a new marker there. And if it's not lying on the model, that discrepancy is the correlation error. And then the prediction error. So in addition to the correlation model, CyberKnife also has a prediction model, which is used to predict the tumor motion 115 milliseconds in advance to account for system latency. And so the difference between the tumor position estimated by the prediction model and the correlation model is the prediction error. And so the correlation error and the prediction error are recorded for all the patients, and they vary throughout the fraction as well. So I extracted all of these from the log files, and the results were different for all patients, but just as a rough estimate, the correlation error contributed median of 0.2 millimeter systematic error component and 1.1 millimeter random error component. And the prediction error contributed median of 0.03 systematic error component and 0.08 random error component. So the prediction error was pretty much negligible. And then the other 3 sources of errors are these. So targeting error is the difference between the position where the radiation is delivered and the true target position. And this was derived from the end-to-end tests that are routinely recorded at Charlie's. And the standard deviation is what gave the systematic component of the error. And this was different in the 3 directions. And then the deformation error. So we require 3 fiducials to estimate deformation, but at our center we use one fiducial, so we couldn't calculate this independently. So we used a literature-based value and assigned it for the different patients based on their tumor motion. So it was 0.75 for less than 2 centimeter tumor motion and 1.25 millimeter for more than 2 centimeter. And then for segmentation error, this was referenced from a previous Phantom study. And yeah, so those are the different values. So the correlation and prediction error have both systematic and random error components, but the targeting, deformation, and segmentation error only have systematic error components. And putting those values in the formula, so every patient would have unique values of these parameters. And so you would get patient-specific margins in the SILR and AP directions. And so these are the main results. So the isotropic patient-specific PTV margin is sufficient for 95% of the cases. Were so these were different for the 3 directions, but if you are considering the maximum of it to give the isotropic recommendation, it would be 3.8 millimeter in peripheral and 2.8 millimeter in central or ultracentral tumors. So this is quite a significant reduction from the standard 5 millimeter that's used, especially for central and ultracentral tumors, where it could significantly reduce the toxicity. And so another thing to consider is that the correlation errors which are contributing to these margins, they also include the treatment interruptions. So correlation errors more than 5 millimeter is usually when the CyberKnife has a soft stop. So it stops temporarily and the issue needs to be resolved before it can be continued. This could be because of cough, deep breath, irregular breathing, and other technical errors. So I did a sensitivity analysis to check the impact of these interruptions on the margins as well. So in this figure, the red points are including the interruptions and the green points are without the interruptions. And the blue lines are the isotropic recommendations that I mentioned about. So 3.8 for peripheral and 2.8 for central. So before excluding interruptions, 5 peripheral patients and 2 central or ultracentral patients had margins in one of these directions to be more than the threshold. And after excluding them, it was only 1 peripheral and 1 central. And even those 2 margins were very close to the threshold. So after excluding interruptions, it was pretty much the recommendations were good for all the patients. So what this suggests is that these reduced margins are the best for patients with stable tracking. And out of the 122 patients, like only 7 cases here and only 2 central cases had these issues. So those very few cases, if the margin is minimized in clinical practice, those very few cases, especially if they're central, could benefit from replanning. And these are the results as per the lung lobe and anatomical site. So for the lower lung lobes, the recommendation was 4.3 millimeter. And for the upper lung lobes, it was 3 millimeter. So that's also a 2 millimeter reduction. And for the hilar nodes, it was 3.4 millimeter. And for the mediastinal nodes, it was 2.7 millimeter. And interestingly, this also is coherent with a previous study done at Charlie's. So in this previous study, they checked the toxicity of the ultracentral cohort treated with CyberKnife fiducial tracking. And to meet the OAR constraints, they deliberately reduced the margin from the 5 millimeter. But the local control remained high, so 95%. So it agrees with our results in showing that a 5 millimeter margin may not be necessary for ultracentral lesions where the motion is limited. The final aim of my project, so impact of interfraction imaging frequency on correlation model accuracy and local failure-free survival in CyberKnife lung SBRT. So the imaging protocol at Charlie's was from start to 10 minutes, it was every 20 seconds. At 10 to 15 minutes, it was image every 30 seconds. And then from 15 minutes to end of the fraction, it was 60 seconds. The protocol has changed now. So now it's image burst, which is different. But this is what's relevant to the patient cohort that I used. And then for an optimal correlation model, these are the recommendations from the manufacturer. So recommended to keep the correlation error within 2 millimeter, but 5 millimeter is the threshold for when there's actually a soft stop if the errors are more than that. And respiratory coverage is ideally better if it's more than 85%. So respiratory coverage is the percentage of the respiratory amplitude which the model has information on. And the translation motion should be within 25 millimeter, as more than 25 millimeter would give a translation out of bound error. So this is the optimal model. And so in my paper, I investigated how with different imaging intervals, the model performance might or might not deteriorate with respect to these thresholds. And this just describes how I extracted and analyzed the imaging intervals. So the imaging intervals, model parameters, and tumor motion were all extracted from log files. And then I ran a Python script to label for each interval what's the model status, is the beam on or off, or if there are interruptions. And then these interruptions were initially excluded for the initial analysis. And so this is a temporal distribution of imaging intervals across all the patients and all the fractions. So the median here, which is the dark blue line, was pretty close to the imaging protocol, but there was substantial variation, as you can see there in the imaging intervals, so showing that imaging frequency varied across patients and treatment situations. And this shows that with increasing imaging, like as the imaging intervals got larger, the distribution of maximum SI motion increased as well and shifted towards the upper tail. And also the distribution of correlation errors shifted towards the higher correlation errors as well. And this was very significant with the chi-square test. And we can see in the figure on the top that in the larger intervals, the tumor motion even exceeded 20 millimeter or 2 centimeter, like quite a bit, showing that the motion increases in these larger intervals. And for the respiratory coverage, so with the larger imaging intervals, we'd think that the respiratory coverage would be deteriorated because it's not being imaged that frequently, but the results were different here. So the percentage of intervals with ideal coverage, more than 85%, was higher than other smaller intervals, which was counterintuitive. But then I checked the correlation error with respect to the respiratory coverage. And you can see that even with the more than 85% respiratory coverage, the correlation error was quite high, like especially at the 100% respiratory coverage. That line has many markers which are reaching all the way up to like 5 millimeter. So the respiratory coverage may not fully represent the model performance that accurately. And so in the final part of this analysis, to evaluate how these imaging and model parameters may impact the local failure-free survival. So now I included the interruptions back as well and defined these features based on whether they are exceeding their optimal thresholds. And I used these features to do k-means clustering. And the k-means clustering identified 4 main patient clusters. So the worst of these clusters was cluster 4, which included 5 patients. And it had compromised imaging and model parameters. But this was only 5 out of the 122 cases. And for most of them, it was reasonably acceptable. And so the other cluster had optimal imaging and performance, and the other 2 had one of the 2 being suboptimal. And then while analyzing the local failure-free survival across these clusters, cluster 4, which was compromised, really had the worst local failure-free survival. And this was not significant in log-rank test because of the very large confidence intervals. But that's an inherent limitation of the data itself, because even across the 122 patients, we only had 9 local failure. And unless we have thousands of patients, it's difficult to get a good sample size for local failures. But when we did do pairwise log-rank test, the cluster which was compromised showed significantly worse survival than the optimal cluster. And it also showed worse survival than cluster 2, cluster 1, which was suboptimal imaging but optimal model performance. So this shows that these results are hypothesis generating, and that the imaging intervals and their impact on the model performance as well as the clinical outcomes is something to consider. So the final conclusions and clinical implications across all the aims. So regarding the beam modality, 6FFF is advantageous in majority of cases. The 3D printed film and ion chamber inserts mitigated dose blurring and provided reliable commissioning, and 299 patients have since been treated with lung SBRT at Charlie's. The tumor motion in SI direction, it was influenced by tumor location, lung function, and BMI. In LR direction, it was influenced by tumor diameter and previous lung surgery or radiotherapy. And in the AB direction, it was influenced by lung function. The PTV margins for CyberKnife fiducial tracking, the study supports prospective evaluation of using reduced PTV margins patients with stable tracking. So 2.8 millimeter for central or ultracentral tumors and 3.1 millimeter for upper lobe tumors. And the imaging intervals in CyberKnife fiducial tracking, so larger imaging intervals compromised correlation model performance, and this subgroup may have poorer local failure-free survival. And regarding the future work, so the last 3 studies were retrospective, so this would definitely benefit from prospective multi-center evaluation and validation in larger cohorts. And in conclusion, this work gives evidence base to individualize lung SBRT in terms of all of these parameters like beam modality, margins, motion, and make lung SBRT safer. Yeah, thank you.
Any questions?
I've got one just regarding PTV margins. In the literature, one of the big things that gets teased out in various sciences is iterative variability and contouring.